Good evening to everyone. My name is Lê Đức Tâm, a neurosurgeon from Hà Nội Medical University Hospital. First of all, I would like, it's my pleasure to be here to have a short presentation. And I also would like to say thank you, Professor Đồng Văn Hệ, the President of Vietnamese Neurosurgical Societies and Vice Director of Vietnam University Hospital. My presentation today is entitled Ossification of Posterior Longitudinal Ligament, some key reports and a short literature review. My presentation has two sections. The first one, key orientation, and one, the source literature reviews. The first guy is the 70 years old workers with normal medical history. And history present in this, the patient presented to our hospital with complaint of neck pain. His pain was dawn persistent and radiated to both arm, forearm, and hand, with the right side more severe than left side. The neck pain lasts for 5 to 6 years ago and got worse since last year. Recently, he has weakness and numbness of hand and leg, with the right side more severe than left side. This symptom was not relieved by medication. On physical examination, he has cervical myelopathy, which GOA score is 4 points, with finger escape sign and grip and really test positive with positive Hoffman size. He also had quadriplegia with muscle strength grade 2 on the right side and grade 3 on the left side, with hyperreflexia of bicep and brachioradialis and patellar reflex. He also had tingling and numbness of bilateral upper and lower extremities, with the right side more severe than left side, and loss of touch sensation. You can see this is the CT scan, cervical CT scan. You can see the very long ossification Opll from C2 to C4. This is mixed type. We have some index on cervical CT scan with occupying ratio of Opll is 78.5%, with space available for spinal cord is 2.17 millimeters. With C2 to C7 cove angle is 8 degrees, and the K-line kyphosis line is positive. These are the cervical MRI on C3 and C4 level. You can see the hyperintensity of spinal cord on T2 image. This is the MRI on C4 and C5 level with very large ossified mass. Compress the spinal cord, very severe. And this is the EMG test with very severe nerve injury of C5 to C8 bilateral. Assessment and plan. The definitive diagnosis, this patient is severe cervical myelopathy, cervical stenosis due to Opll. Our plan is C3 to C6 laminectomy and fixations. On post-operative course, the patient was treated in ICU for 4 days with mechanical ventilation. He received rehabilitation from the first day post-operative and was discharged of our hospital 10th day. At 5 months post-operative, he has only mild neck pain. GOA score is 12, increased. The muscle strength improved with grade 4, numbness and completeness of hand and leg improved. This is surgical X-ray at discharge day. These are 1 month post-operative, and this 3 months post-operative. And this is the MRI post-operative at 3 months. And this is the second case. This is the 43 years old worker. He has history of right side single door laminectomy C3 to C6 1 year ago in Taiwan. 1 year ago, the patient neck pain and numbness of upper and lower extremities when he worked in Taiwan. He was diagnosed with cervical stenosis due to Opll, and then he was operated on laminoplasty C3 to C6. But after surgery, his numbness increased gradually, with the left side more severe than the right side, and was not relieved by medication. And recently, he has clumsiness of his hand and leg, and has difficulty in walking, but his bowel movement and urination was normal. On physical examination, he has cervical myelopathy, which GOA score is 6 point, with finger escape sign, really test positive, and Hoffman sign. He has the left side hemiplasia with muscle strength grade 4. He also have hyperreflexia, bicep, bronchioradialis, patella. He also have the tingling and numbness of bilateral upper and lower extremities. And the left side more severe than the right side. You can see this is the cervical X-ray, the AP and lateral view with the laminoplasty from C3, C4 to C6 on the right side, single door. Did the CT scan. You can see the very long Opll from C2 to C6, C7 with mixed type. This is ossified mass on CT scan. On CT scan, we calculate the occupying ratio of Opll is 62%. The space available for spinal cord is 5.9 millimeters. We see C2, C7 curve angle is 2 degrees with K-line positive. And this is a cervical MRI scan. You can see the high intensity of spinal cord on T2 image right here. And this is an A0 image. This is the ossified mass still compress the spinal cord on the left side. This is on the right side. This is EMG test. EMG test patient have a dysfunction of C5, C6, C7 bilateral. And assessment plan. This patient have definitive diagnosis is persistent with cervical myelopathy due to Opll. The mixed type, he was underwent laminoplasty C3 to C6 on the right side. And the plans is in our discussion today. And I would like to review a little bit about treatment of Opll. Until now, the treatment consists of two methods. The first one is conservative treatment. The second one is surgical treatment. In surgical treatment, we have three approaches. The first one, anterior, posterior, or combined. In anterior, we have ACDF or ACCF. In posterior approaches, we have laminoplasty. Many methods of laminoplasty like this one, single door or double door, or laminectomy alone or laminectomy and fusion. Regarding to conservative treatment, the indication of conservative treatment is a symptomatic patient without severe cost compression or myelomalacia on CT or MRI scan. Conservative treatment include physiotherapy, cervical orthosis, etc., and activity modification with avoiding high-risk activities. In conservative treatment, the patient should be followed closely and get returned to clinical instruction for sign of myelopathy. This is because approximately 70% of asymptomatic patients develop myelopathy at the mean of 14 years. Although prophylactic surgery for asymptomatic patients is not routinely recommended, the patient with severe stenosis cervical segment and cause signal trend should be closely monitored and questioned for signs symptoms of myelopathy. The patient also should be educated about the increased risk of spinal cord injury secondary to trauma, because in patients with cervical spondylotic myelopathy, the other trend reported Opll to be increase the risk for spinal cord injury with hazard ratio is 2.24. For surgical treatment, we have anterior approach. Anterior approach is where have advantage for direct compression of spinal cord by impinging Opll and address concomitant compressive spondylosis, followed by fusion and instrumentation of segment involved. In case of cervical kyphosis, anterior approach is superior for restoring lordosis and adequate spinal canal decompression. And multiple studies have suggested patients with canal occupying with 60% undergoing either anterior or posterior decompression. And anterior approach results in superior clinical outcome. In this case, UOA score and recovery rate. And more recent techniques focus on floating of ossified mass. This is because approximately 30 to 50% of all Opll lesions will have dural adhesions. And the floating method is performed by rejecting the overlying vertebral body and release ossified PLL from its vertebral body and or this attachment. But the anterior floating methods require the Opll should be thin to less than 5 millimeters and a minimum of 20 millimeter width of decompression. However, anterior approach had very high complication rate. The first one, dural tears. Some study reported up to 20%. This is due to attenuation or adherence of the ventral dura to OPLs. And primary repair with dural sealant should be attempted when possible. However, some case we need to autogenous fascia or synthetic collagen graft may be necessary with larger defects, and lumbar drainage for CSF can be considered for tenuous repair. The second complication is nerve root pansy. It's 4 to 17%. It's most commonly is T5 distribution. In case of post-operative nerve pansy resulting to significant weakness, the urgent MRI should be considered to rule out the epidural hematoma, as well as sufficient decompression of cervical levels. And the last one is pseudoarthrosis and graft migration. This may be up to 15 or 11%. And anterior approach can be benefit from adjunction posterior instrumentation fusion, when the anterior approach extend more than 2 levels to prevent the graft-related complication and reduce the risk of pseudoarthrosis. For posterior approaches, the indication is for the long segment more than 3 levels of spinal cord compression, and in case of the K-like posterior. We have 3 methods. The first one, laminectomy only, laminectomy infusion, and laminoplasty. The first one, laminectomy, this have advantages. It increases 70 to 80% of canal volume, but the risk of cervical kyphosis due to disruption of posterior ligamentous and paraspinal muscle attachment. And 92% of the patient exhibited post-operative reduction in cervical lordosis, but all patients maintain their neurologic post-operative improvement. And OPL progression with laminectomy without fusion is in 56%, very high, by 2 years, especially for the patient, younger patient and mixed and continuous tie OPL. That's the reason why some patients we need laminectomy and fusions. And this method have advantages in it's hold the progression of OPL and maintain intraoperative lordotic cervical alignment. But we have to sacrifice the cervical range of motion. And the last method is laminoplasty. This is alternative for motion sparing. And this improves the GOA score between 40 to 60%. And the optimal indication for laminoplasty is the patient with less than 60% of occupying ratio and lordotic alignment of cervical spine. In higher T1 slope angle is the good predict to greater post-operative loss and cervical lordosis. While laminoplasty allows for continuous motion, that reason why OPL can be progressed in upwards of 70% of patients. In other reported, laminoplasty alone increased 5 times of OPL progression to laminectomy and fusions. And the risk of progression of OPL after laminoplasty is higher in younger patients and in case the OPL ST3 levels, and most frequently the progression ST2 to C4, and most progression see the C2, 42% of the patient. And laminoplasty also have disadvantages in case of K-like positive in upright lateral X-ray, but on the flexion view, the K-like is negative. This case may have significant lower GOA score post-operative than the patient have K-like positive on flexion X-ray. This is due to when the patient flex post-operatively, the spinal cord can be compressed. And subspine pre-operative hypermobility may be a poor prognostic factor for laminoplasty. And laminoplasty also have some complications. For example, spinal cord injury intraoperative, nerve root injury, closure of lamina, fracture of laminoplasty, hinge, progression of OPL, and etc. And that's the reason why recently we have a modification of laminoplasty, such as avoiding laminoplasty at C3 and C7, and this leads to a decrease in post-laminoplasty neck pain. And the optimal patient for laminoplasty is the patient with canal occupancy of less than 60% and short duration of symptom less than 1 year, and cost signal trends on pre-operative MRI image. And laminoplasty with less than 50% OPL canal occupancy have equivalent outcome to anterior approach with less complication than anterior approach. And this is some meta-analysis. This is meta-analysis published in 2017, with 6 studies was included. In totally 123 patients undergone anterior cervical corpectomy ACCF, and 216 patients had posterior approach. The meta-analysis result is the post-operative GOA score of anterior surgery was higher than posterior surgery as 1-year follow-up, and recovery rate of anterior surgery was higher than posterior, but the anterior surgery had more complication rate compared to posterior surgery. This is another meta-analysis in 2017 of 10 study containing 735 patients. The main result is there's no obvious difference in preoperative GOA score between ACCF and laminoplasty. But in subgroup A, this means that if the patient have occupying ratio less than 60%, there's no difference in postoperative GOA score and recovery rate between ACCF and laminoplasty. In group B, the patient had occupying ratio greater than 60%. The ACCF had higher postoperative GOA score and recovery rate than laminoplasty. But the complication and reoperation of ACCF is more higher than laminoplasty group. And for the C2 and C7 cup angle, there's no difference between the laminoplasty and ACCF, but ACCF had more operating time, more blood loss. And the last one is the reviews in 2020. This is review by choosing approach for the OPL patient. The main reason is that for the patient with K-line negative, regardless the canal occupying ratio, anterior approach is the preferred approach. For K-line positive, canal occupying ratio greater than 60%, anterior approach is preferred. And for K-line positive, canal occupying ratio less than 50 to 60%, posterior approach is preferred. Especially for the last multiple level OPL with K-line positive and small OPL, this means ossified mass is less than 6 millimeters, laminoplasty is the preferred approach. And this table summarizes the main result of this study. And in conclusion, I would like to summarize some advantages and disadvantages of different approach. For anterior approach, we have ACDF and ACCF. These have advantages of direct decompression of spinal cord, superior for restoring lordosis, and superior clinical outcome, GOA score, and recovery rate, and can be used in the patient with K-line negative. But disadvantages is long operative time, high blood loss, especially for ACCF, and some difficult for the patient with osteoporotic bone, and we only often use for less than 3 level of OPL with a higher complication rate in many studies. For laminoplasty, have advantages of can be used for multiple level, motion sparing alternatives, less operating time, blood loss, and in many studies, this method had the highest 5 years quality of life. But disadvantages is the patient have to K-line positive, because if the K-line is negative, the spinal cord strip is adequate after surgery, and progression of OPL, especially after 2 years post-operative, and the patient may experience post-operative atrial neck pain. The last one, laminectomy and fusion. This can be used in multiple level, can halt the progression of OPLs, can maintain intraoperative lordotic cervical alignment, but the post-operative atrial neck pain is a disadvantages, and the patient have to sacrifice the cervical range of motion. And that's all of my presentation. Thank you so much for the attention. Professor He.
Good. Thank you very much, Dr. Tom. Next, I would like to invite Dr. Mike Dr. Mike, please. Mike, can you hear me? Oh. Hi, Dr. Mike.
Hello. Hi. Can you hear me?
Yeah,
Hello.
right. Yes, please.
Okay. A minute, I share my screen. Hello. Can you see my screen?
Yes.
Okay.
Yes, please.
It's okay. Okay. Good evening, Professor Chairman, and good evening, the member experts. Good evening, everyone. I would like to review to present some reviews of cervical Opll. Some introductions. As you know, this disease can occur anywhere of level of the spine, but it's not common in level cervicals, around 75%. So today I focus in cervical Opll. What is this Opll? Opll is ossification of the posterior longitudinal ligaments. It's referred to ectopic calcification of the posterior longitudinal ligament in the cervical spine, which may result in cervical myelopathy due to compression of spinal cord or nerve roots. And it was first reported by Japanese doctor. His name Shikimoto in 1960s. About epidemiology, the first serialized you see here is the number from Japan. As you know, when you talk about this disease, you think about Japanese because this disease associated with Japan and Japanese. And in Japan, around have 27 per 100,000 populations, and there are lots of in Japanese compared with other countries. In Caucasus, I mean in white people in Europe and Americans are fewer, and the males is double compared to female. For now, we don't know the cause of Opll, but have many risk factors. For example, it's come from genetics, environmental factors. Here is the very last number, more than 50,000 patients in epidemiological study in Japan. It shows predominance in men. The age around 65 years old. It's with a big number of patients. What happens when Opll mass in cause the spinal cord will become progressively damaged over time and will show up on clinical imaging and pathology image. There are 4 degrees from state 0 to state 3. and the level gradually increased from normal to very severe damage. And he saw well on imaging MRI T2s. There are many classification of types of Opll, but I think the most the most important and the most famous is come from Japanese health. There are 4 types, type A, B, C, and D, and sometimes they said is type 1, 2, 3, and 4. With type A is the type its name continuous, around 27%. Type B is segmental, 38%. And type C is mixed, type A and type B, around 29%. And type D is localized, and other name is the big type or circumscribable. And you see in the Dr. Tâm presents the first case is the T type A is continuous, and the second case is the type C mixed. You can see in the CT scanner, it's here, it's a continuous type, and here it's a segmental type. That means it's the mixed type. And in outside we can see in the Asia slide with the shape, hue, and square, and mushrooms. And they say that the hue type, square type, and mushroom type. And sometimes we have a special imaging when you see the double layer. Here is Opll mask, and here is dural calcifications. With clinicals present are also very variables, maybe asymptomatic and maybe symptomatic. With asymptomatic, the patient maybe discovered by accidents during general examinations or after radiography or after menotrauma. And with symptomatic, maybe the person in progressive with axial pains, numbness along the arm, for example, radicular, other symptom of neurological deficits. It's called myelopathy or myeloradiculopathy rather than radiculopathy alone. And sometimes the symptom combined with some condition the patient, for example, diabetic or hypoparathyroidism or myotonic muscle dystrophy. Here is a Nuri scale to evaluate the patient. This scale is famous in Europe. We can see the grade from grade 0 to grade 6. Grade 0 is no root. That means the patient is normal in the clinical. And grade 6 is the severe patients. And from grade 3, the patient, the doctor can could decide to operate. Here is MZOA scales. It's very famous in the world for now from Japanese doctor. This scales based on the motor dysfunction of arm, of neck, and the sphincter dysfunction. And this is normal. It's 18, and normally less 14 the patient has indication for surgeries. Brain radiography is very basic. From C3 to C7, you can have a canal diameter around 17 millimeters. It's normal stenosis when less than 10 millimeters. And besides that, you can see the type of Opll. For example, here you can see the continuous type, with plateau shape image. And the next is a circumscribable type or hinge shape in image. The CT is very useful when you have Asian thin slice, and you can reconstruct 2D and 3D image. With the Asian slide, you can see this image square, hill, and mushroom is a special image. Here is a summary of all type of Opll, cervical Opls in CT scanner. Here is a slide. You can see various images. Sometimes you can see a special picture. For this, you can see the C size in the rest, and you can see the bilateral C size and double layer in, and you can reconstruct 3D in the CT scanner. MRI. The MRI can provide the information regarding spinal cord structure and associated soft tissues, abnormals, and CV junctions. Here, you can see the MRIs provide associates with this herniation, and the differentiation between multiple disc and early Opll by contrast enhancement, and can provide the image pathological change in spinal cord. And from to bottom, you can see boomerang image, and you can see the teardrops imaging and triangular imaging. Sorry, it's not working. K-line is very information to doctor. K-line is a line drawn from the middle of spinal canal at C2 and C7 levels. When the mass Opll in front of K-line, that means this K-line is positive. And when the mass the same K-line positions is K-line is negative. Is K-line is positive and K-line is negative. In X-rays, the first is K-line is positive, and K-line is negative. And in CT scanner, you can see is K-line positive with type continuous, and here is K-line negative with the type mixed continuous with segment. X-ray is K-line positive and in cities, K-line negatives. With radiological science help the doctor choosing approach when do surgeries. The first is occupying ratio. When this number more 40%, it indicates high risk of the developer myelopathy and more risk of posterior decompression, especially with huge shapes ossifications. And the second number is SAS, it's a space variable for the core. It's normal when more than 50 millimeters. From 10 to 50 millimeters is the cervical steroids, but it's not sure. But it's stenosis when under 10 milliliters. And the K-line is said before. Treatment in general, we have two steps. First is non-surgical treatment, and the second is surgical treatment. With conservative treatments, normally is indications with the patient no symptom. With subclinical myelopathy, meaning so dynamic compressions, I mean less than 60% stenosis, or sometimes it's bad condition, for example, severe comorbidity. Some techniques for conservative is polar traction or change lifestyles. With the surgical management, with purpose open the spinal canal by decompressing bony rings, but protects maintain ligament. Indicates general for acute or chronic progressions of neurological diseases. This progressions is very important. And in MRIs, we can see the signal intensity change, especially in T2. For surgical indication details, with the patient with myelopathy or radiculomyelopathy with predominant myelopathy, with role of prophylactic surgeries in asymptomatic patient when the patient have a severe canal compromise or such less than 6 millimeters or occupying ratio more than 60%. And in MRIs, you can see presents a call signal. It favors more for the young race, less than 65 years old. About surgical techniques, surgical procedure, we have three main parts: anterior surgery, posterior, and combined. For anterior surgeries, normally we use a single lever, sometimes multiple lever, but less 3 or 4 lever. It's good. With some techniques, corpectomy with remove conceived mass, or corpectomy without remove conceived mass, with anterior floating methods, I will present after open window corpectomy. Is one of techniques. Oblique cervical corpectomy with fusion and hollow vest or with fusion fixations. For posterior surgeries, everyone knows two techniques, basic techniques: lamellectomy, fixation and fusion, and lamelloplasty with some sub-techniques, for example, open door, double door, lamellectomy. and combine the anterior posterior. Some case is not common case. Choice approach. One of important things for doctor choice which approach. There are some suggestions for doctor choose approach. With anterior approach is candidate is occupying ratio more than 60%, and with high shape calcification, kyphotic deformity, or degenerative instability, but limited corpectomy level up to 4, but sometimes, often we find 1, 2, and 3. And of course, with the experienced doctor and the condition of hospital, we favors for posterior approach. We based on the first is community prevent more lengthy procedure. Occupying shapes. Yeah, I was wrong. Occupying shapes less than 60%, and plateau shapes calcification in image. And of course, preserves lordotic spine or maximum shattering. Anesthesia is general anesthesia patient in intubations and have some machines to help the doctor to control in operatives. With a posterior approach, we have 3 techniques, 3 main techniques. Williamectomy is benefit is simple techniques, effective in selected cases, but have many disadvantages. For example, the scar formation may compress core, and higher incidence of kyphosis and instability, or higher incidence of Opll progressions after surgeries. The laminectomy we open from C3 to 7, and sometimes we do facetectomy around 25% for root decompressions. Laminectomy and physician infusions have advantage is reduce the risk of posterative kyphotic deformity and spine instability, because there are physician and combo fusions. But some disadvantage is potential risk is the risk of arteries injuries and more lengthy procedure. With some techniques, we can use caps, sublaminar interspinous or facet writing techniques, or screw and rods with plate construct physicians when use techniques. One of important technique is expensive lamelloplasty, have more advantage. It's simple and related with low complication risk and less risk kyphosis and deformity, less risk of scar tissues, compressing core. Some disadvantage is the risk of Opll progressions or limits effective in severe kyphotic deformity. Something is open door, one side, two side, Hirabayashi, and so on. For anterior approach, normally we use single or multiple level, less 3 or 4 level, with techniques corpectomy with remove cancer field mass, or corpectomy without remove cancer is floating methods. Or we can use technique open window corpectomy oblique cervical corpectomy, of course, with fusion and hollow vest 6 to 8 weeks. Here's technique corpectomy and remove cancer mass. The first we do the similar ACDFs. After that, the corpectomy and some notes, some attention, and 3 layers bone cortical cankerous and cortical postvestibular. But do not separate the third layer from lateral gutter, thin walls, and separating the third layer completely in opioid flooding, and try to dissect the mass from dura. This technique attention with tear dura is maybe called CNF leak. Here I explain some techniques. First is anterior. It's anterior floating methods. I want to explain something. The anterior floating methods thins ossification and disconnect it from the surrounding bony tissues. When freeing the ossification from the surrounding bone tissue, the top and the bottom end of the ossification are first relieved transversely and then disconnected from the pedicle and thus situate lateral. When the thinner Opll appear to be like a ball floating on water, the compress of spinal cord is complete. Yes, it's why it's named floating method. Doesn't mean we don't remove the mass OPLs. Just we drain the thinner, and after that the mass concentration is floating like a boat in the water. So it's named floating method. The next is open corpectomy, open window corpectomy technique is designed to remove a minimum amount of bones and achieves satisfactory decompression with the use of high-speed drill under surgical microscopes. Only dorsal surface corpus is removed after appropriate microdiscectomy. This level, the anterior and lateral portion of vertebral cortex intact is not so last in when we drill the vertebra. And the last is oblique cervical corpectomy. Oblique cervical corpectomy, then we direct decompression of the spinal cord as well. Ipsilateral nerve roots, but not requires bone fusions or post-operative immobilizations. This approach preserves the motion and units anatomy and decrease the risk of section 6-month disease. Yeah, it's oblique. After that, I saw some research, some study and focus with indication surgery and how the doctor choose the approach to do surgeries. For this study with cervical OPLs with single or double never, they use anterior approach with more 3 level, depend on some number here. the patient can use anterior approach or posterior approach with lamellectomy, infusion, and lamelloplasty. And as a study about around more 300 people with cervical myopathy, OPOLs, you can see with single level we use ACDF. If not, depend involve segments more or less 3. We can choose which approach. Here is anterior approach. Here is a lamelloplasty. That means posterior approach with prognosis K-lines positive, or laminectomy infusions with flexible kyphosis, or combine anterior and posterior. And the next here is as a study based on cervical myopathy with we can choose which approach for them. And here is a simple picture for cervical OPL with based on K-lines positives, lamelloplasty, or K-line negatives, depend age and this clinical situation. We can choose the anterior approach or posterior approach. Here is a study from India, and the doctor in the summary the indication for choose anterior approach or posterior approach. It's the same information from Dr. Tâm before. Another study with the indication of anterior approach when the patient localize the compression in the kyphotic curve, Opll occupying ratio with a kind of diameter more 50%. Some prognostic factor. First is the patient factor, include all patients preoperative neurological, that means it's clinical history trauma. From disease factor is occupying ratio or sex associated set ossification. For example, huge shapes is very weak posterior decompression. And the last is management factor. Progression may be more with posterior decompressions. In the Japanese with statistics, they found 19% surgeries were performed with posterior approach, and 0 score when indications around 11 points. There are lots of complications. We don't have a time to talk about complications, but if we have a complication, mostly it's CSF and it's maybe not too bad to decide. The conclusion. For now, there is no recognized guidelines for the diagnosis and treatment cervical OPOLs, especially for the choice of surgical methods, and various of decompression methods have their advantages and disadvantages. Especially there are more complications when we do Opll surgeries higher than other cervical surgeries, it seems posterior approach the doctor use often than anterior approach, and ACAF's technique surgeries it seems to be great hopes on the future. I finished my presentations, and I hope to give you some information and something new for everyone. Okay, thank you, everyone.
Okay. Thank you very much, Dr. Wang, for the beautiful presentation. And next, I would like to invite Dr. Hao. Dr. Hao, please. Do you have some comment or question?
Yeah, thank you for 2 nice presentations. From your presentation, I have a lot of useful information for clinical practice. So I want Dr. Thâm the one question about do you know about the selective laminectomy or serology technique from Japan?
Okay, thank you for the question.
Dr. Thâm.
Thank you for the question. Actually, for laminectomy, we have only know 2 techniques: the single door and double door techniques. And about your Japanese name techniques, actually I don't know.
So Dr. Shirashi, he's study very carefully about the posterior motion in cervical spine. So we found most patients kyphosis after surgery because we destroy the attachment of the muscle.
Yeah.
So he advised we in the operation we should conserve the attachment of muscle. So he found he creates a new technique. So he's conservative the attachment of muscle in the posterior posterior approach, posterior I don't remember. So he calls that skip laminectomy. It means for example, we have Opll from C7, C3 to C7, laminectomy from and C4, and C open the laminotomy from the C3 or C5 or C6. So totally canal, spinal canal is widened, but she's conservative the attachment of the posterior muscle. So after surgery, the patient have no progress of kyphosis. For long term, the reason for Opll operation, the patient with the management by the serology technique or selective laminectomy is a best reason from the anterior or posterior, for example, laminoplasty in Japan. for me, I know. So I think Dr. Xie have a lot of students from Vietnam, from north to south. She teach his technique for the manner doctor in Vietnam. For example, in the north, you can learn from the Dr. Wang from the Saint Paul Hospital, or Dr. Quyen, Dr. Thuan, 108 Hospital, or in the south, many doctors in the south, in Ho Chi Minh City or Cần Thơ City, many doctors from Vietnam to study skip laminectomy in the Japan with the Dr. Shirashi. I think it's a very famous technique in Japan.
Okay, thank you so much.
Okay, thank you very much, Dr. Hao.
Yeah,
Next,
welcome.
I would like to invite Dr. Tian. Do you have some comment, or how about your opinion? Question, Dr. Tian, please.
Thank you so much for your attention, but tonight I no opinion. Thank you. I have no opinion.
Okay. Okay, thank you very much. And how about Dr. here? Dr. here, please.
Yes, thank you, Professor. Thank you to Dr. Tam and Dr. Mike for very nice presentations. As I remember, I'm sorry. Do you hear me? Do you hear me?
Yes.
Clearly?
Yes.
Okay.
Yeah.
Thank you. As I remember, is this pathology is not yet not have lecture in the textbook of Vietnamese medical schools, right? Because it's it's not very popular, and it's a rare pathology, but it's maybe can it is not very rare when a neurosurgeon can meet a case like that, but in the population, for example, as in the statistics you have in Asian, it's about 1%, and it's a 10 times more than Caucasian. Scientists don't know yet why, but the first one who described this pathology is not Japanese doctor. Is England, in London, in 19th century. Cervical. So after that, it's not no more report about this pathology. And from 1960 in Japan, Dr. Tsushimoto described this, and now you have more and more report about this pathology. So when you I'm sorry. When you talk about spine, and especially the cervical spine, there are many controversy, right? In the trauma, in tumor, in the vascular lesion, and other in the stenosis, and so on. And that means this the technique is controversial, and when you surgery or not, anterior or posterior approach, and fusion or not, etc. And when you choose approach to treat, you have to must to consider the pathology. All right, and here the most thing consider for neurosurgeon is myelopathology. Okay, so I think you have to discover the myelopathology in I'm sorry, you can think about to take image of the spine when you have the patient come with you with myelopathology. In the treatment, I see here I review some of article and chapter about this, because it's not very popular, that like literature. And the pain, only pain, the patient with only pain is not very recommended for surgery. So you have to, because why? Because the surgery, when you when you operate to eliminate the ossification, the pain is still there. Okay, so you have to surgery or not surgery in the patient with only pain as symptom is controversial. The second controversy is in the case of severe spinal stenosis due to Opll. Do you have the surgery or not? And the patient have any symptom. That's the controversy. The third controversy in here is the patient do you have prophylactic surgery, as Dr. Mike had said in the presentation. But I think sometimes the prophylactic surgery is maybe useful when the case the patient can have tumor. Okay, do you remember? I have you have is not very not rare. The patient with cervical tumor, and because of Opll, and the patient the tumor, the spinal cord tumor is more severe. Okay, so I think in the patient in the case of patient with high risk of cervical tumor, you can consider as a prophylactic. Is not you have to discuss about that, but that's all. Is that three point of controversy in here. The technique of surgery, I don't discuss here because it's a very controversy, and it's the choice of surgery. It depends on surgeon. Okay, but I think with posterior approach, you can do anything in the in this pathology. Okay, laminectomy or laminoplasty or many technique. I think the first report from 1960 until now is only 60 years, and the technique of surgical spine is still developed. Okay, is still in developing. So you can choose each surgeon can choose the technique appropriate to the each patient. Okay, and I have one. I have no question, but I have suggestion for Dr. Tâm, because you have a case report. So, and in the controversy is not so common pathology. You have to analyze the choose was your choice for treatment. Why you choose that approach for that patient? In that case, why you don't choose the anterior approach? Why you choose the posterior approach, etc. Okay, so your presentation can be deeper in its knowledge or in more in detail in that topic. Okay, that's all. I finished. Thank you.
Okay, thank you very much, Dr. Hiệp. And next, I would like to invite Dr. Lê Nghiêm Bảo. Are you there, Bảo? Okay.
Hello. Good evening. Good evening. Can you hear me?
Hi, Dr. Badra.
Yes.
Hi. I would like to invite all of you, my friends, Dr. Badra. He's a young neurosurgeon. He's come from Mali,
Yes.
Africa. He spent some weeks in my department to study neurosurgery. Dr. Badra, do you have some comment or some question?
Okay. I think
Or maybe do you have some case like that? Do you have some Opll case? And if you have a case, please talk about something about that. Or if you have some experience or question, please.
Yeah. Thank you very much, Prof. Thank you very much. I'm really happy to be with you in this meeting, Zoom meeting. Sorry for the noise because I'm still in the I'm still in the one restaurant here. So I don't know if you are hearing me very well. Yes,
yeah, I hear you. Okay.
Yeah, I have some cases done. Like we did 4 cases with those ossification on the posterior ligament. Yeah, yes, and I'm really happy. And for those 2 presentations one done by my friend, Dr. Mann. Yeah, that was very nice, and I really appreciate them. So in terms of those, I think as Dr. Mann say, there is no up to now guidelines in terms of which approach to use. But it's obvious most of us we like to use the posterior approach, doing laminectomy or laminoplasty from whatever, from C3, it depends where the compression is. But for me, there is other information very important that you must look if we have those kind of patient. Since when the patient starts with the first symptom, when the first symptom starts, that can give us an idea how the compression, the spine was under compression from when to when. That's one. And the second thing, the time the patient will come to us. So we need to see the grade of myelopathy, like using the classification that Amen was using, Nuric 1, 2, 3. For me, from Nuric 1 up, Nuric 3 up to 5, 6, So I think those can have a severe complication during the procedure. And also another, the prognosis, I think it will depend not only of the grade of compression, but during the surgery itself. Because for me, we did 4 cases, but one came, the last patient, it was this year in February, the patient was quadriplegic post-operative, unfortunately. But I think there is a many factor, but one of the factors very important for me is to control the blood pressure during the procedure, the time we are doing laminectomy or laminoplasty. Because you can do gentle laminotomy or gentle laminoplasty, since the spinal cord was under pressure for many years, and all the vessels, they was congested. So the moment you are doing laminectomy, even if it's gentle, you will find the vessels, they will come intraspine, intramedullary, they will come decongest. So if the blood pressure is not well controlled, that also can contribute in the patient condition to become worse and worse after the surgery. So for me, those are the factors we need to see. Like when we are doing laminoplasty, the time to decompress the spinal cord, we need to check the blood pressure. So we need to make sure the pressure must be low when we are doing the decompression. Yeah, and that's one. And the second thing also, of course, we need to be gentle during the procedure. And I think the anterior approach, the anterior approach for corpectomy, doing corpectomy 1 or 2 levels, for me, it will depend if the dosification is only 1 or 2 levels. But if it's like 3, 4, or 5 levels, more than 3 levels, I think corpectomy is supposed not to be the good idea. Yeah, always going from the back, but going also from the back, we need to consider and explain to the patient that the high risk to become plegic or the motor defect can be more it's coming worse and worse after the surgery. I think we need to explain better to the patient. Yeah, so that's my contribution, because we had very bad experience in the beginning of the year. So yeah, we did 3 patients like 2 weeks ago, 2 months ago, sorry, 2 years ago. Those went very well, but the last case, it was very unfortunate. Yeah. Thank you very much, Prof.
Oh, thank you very much, Barbara. Thank you very much.
You're welcome.
Yes, next I would like to invite Dr. Quang, Dr. Nguyen Quang, please. Do you have some comment? Dr. Lê Nghiêm Bảo. Oh, hi.
Okay, so
How are
thank
you?
you very. Hi, how are you? Very good.
Hi, thanks. Yeah.
You know, because tonight my iPhone a little bit had problem. Hey, you hear me?
Yeah, yes, I can hear you very clear.
Yeah, yes, good.
Okay. So thank you very much for the presentations, Dr. Thum and Dr. Man. And I think that is a very rare, you know, very rare cervical spinal myelopathy. And in my life, I just met 2 cases, a very simple one. It's like it's kind of circumscribed type, and we, you know, deal with it. We deal with it like you know, the hard disk herniation, of the C5, C6, and we do the ACDF, and we do the plate screw, like you know, routine, and the rest kind of continuous type, segmental type, or mixed type I never met because they're very rare. And so my my comment about this topic is about laminoplasty. And laminoplasty is a widely accepted surgical procedure for Opll, especially in Japan. Everybody knows that Japan very famous about the Opll surgery. But I think if Opll with the significant cervical kyphosis, it often, if we do the laminoplasty, it often deteriorates into the unfavorable result because the bowstring effect, so I think the laminoplasty should be avoided in patients with significant, preoperative kyphosis or Opll with canal compromise of more than 50 to 60%. So I think so. And my question for Dr. Thum, if because sometimes the way we treat to cervical spondylotic myelopathy and Opll look like it's similar sometimes, but no matter what you do, have you met a post-op C5 palsy, and it's not very serious complication or problem, but sometimes the patients, he or she doesn't like it very much, and they complain about it very much. And have you ever met this problem? And if you meet this problem, how do you cope with? Okay, thank you.
Okay, thank you, Dr. Bao, for your question. I have met the patient have a post-operative C5 palsies. Surgery, yeah. Yes, but I think the first solution is we have to wait, because most of cases C5 palsy will restore for 2 or 3 months, and I think so first we should wait with after surgery, and the patient may have resolved the C5 palsy. And in our hospital, the patient also received the rehabilitation post-operative to facilitate the recovery of C5 palsy.
And mostly, C5 palsies, take place after anterior or posterior approach. What do you think? Which one? Which approaches?
Mostly is the posterior approach.
Okay.
Because when we retract the shoulder too much or in a wrong direction, you can have the C5 palsy. I have met 1 or 2 cases before.
You mean over distractions, right? Over distraction.
Okay. Over retraction.
Because sometimes we, when we pay attention too much about how to do a surgery, we forget that. We forget to leave it, a little bit less tense. So we over distracted because we want to have a very beautiful, surgical field. That's right.
Yeah, that's right.
Okay, that's right. So we forget it. We forget. Okay, thank you. Thank you.
Thank you so much.
Hello, I have some comment.
Yes, please. Yeah, please.
Okay, can you hear me?
Yeah, right.
Okay, thank you. The first, I agree with Dr. Hậu, Dr. Hiệp, and Dr. Bao, and I sympathize with Dr. Barbara from Malaysia. When I prepared these slides, these topics, I have read some study on those some article from this disease, and I see in fact it's not easy. It's not easy, and more I read, more I feel it's difficult. I give 3 main reasons for my opinions. The first, for now, I don't find any guidelines for everyone, for every countries in the world. Maybe I can see from Dr. Japan's, but it's just for Japanese, and it's not for every countries. For why it's a famous disease in Japan, Japanese, and Japanese doctor is excellent, but they don't give an acceptable guideline for everyone. Maybe just for Japan it's okay, but it's not for everyone. And for now, of course it's famous in Japanese, but for now, if you see in internet, you see in many conferences have more and more research from China. Yes, China is becomes a big boss besides the Japanese. And when Dr. Japanese and the Dr. Chinese sit down together, but they don't reach the guidelines, just consensus. That is the first reason I said why it's most difficult in Opll disease. The second, if you number the technique, the surgical technique, around 10 and more 10 surgical techniques for this disease, for surgical Opll. That means it's a very huge number, and it's not easy to choose correctly. I think so. And the third reasons is the complications in general, the surgical complication up to 21, exactly 21.8%. Yes, it's huge. It's disaster, and it's I think it's higher than any surgical spine. Yes, of course. So as like Dr. Bao says, it's also rare in Vietnam, and I think if we have a condition, we have topics like that, it provides more information for everyone. Okay, thank you.
May I speak, please?
Yes, please, Dr.
Yes. I don't know if it can be. I continue the last what I said. I don't know. I don't know if because the Japanese doctor is the first described from 1960, and that means there so many patients have, can be seen, can be discovered. But that's I know this mean in the I think in Vietnam, for example, or other Asian country like Indonesia, very populated. The patient is not. It can be. It can be. You can be have many patients, but because the patient then come to neurosurgeon, So you can have, because they come in neurosurgery department only when they have symptoms. That's right. And in China, they have a scanning, CT scanning of about 10. When you have a statistic about 1.8%. It's about it's because they have a scanning study in the normal people, about 700 person, and you discover about 1.8% people have Opll without symptoms. That's why. But if in the Vietnam, if you have a scanning study like that, you can discover more patient. Okay, I don't count that patient because they have any symptom, but they have a pathology of Opll. And the second thing, why? Because why they have not yet consensus. Why? Because a very variety of symptom, variety of treatment approach. So you can classify this pathology at in like pathology in controversy, in discussion, right? But you have to use the rule of neurosurgery. That means when the patient have neuropathology, you have to decompression. That's mean when you choose the anterior approach or posterior approach, you have to consider if the best compression for pathology and minimize the complication, or minimize the cervical spinal cord contusion, spinal of surgery. And I think the most the gold standard here is the patient, not highlight the patient. If the patient have release of pain, release of neurological deficit, etc. So on, that the gold standard. That's all. Thank you.
Okay, thank you very much, Dr. Hiệp. I would like to invite Dr. Nguyễn Quang from St. Paul Hospital. Quang, are you there? Okay. And how about Dr. Quỳnh, Tô Văn Quỳnh? Quỳnh, do you have some question or some comment? Tô Văn Quỳnh. I may have a question for all of you. Do you have some case? I'd like to talk about the calcification or on 1 or 2 level. That means it's not the ossification is not too long. Some author advise to do the anterior approach. They would like to remove the calcification Do you have some experience about that? And how difficult when we try to remove the corporectomy and we do at the same time remove a calcification? You understand? Dr. Mạnh, do you have experience about that?
It's not easy questions. Yes, if in the past and before, I think it's my answer is easy. It's anterior approach, but for now, I would combine some factor, some other factor. For example, I would like to see the K-like if you mean 1 or 2 level, and it's not so long. If normally it's K-line for this case, normally the K-line although it's positive, and with if we don't have any experience, any special results, I think the anterior approach is more favored. It's more favored. But with anterior approach, we also have some techniques, ACDF or ACCF or ACAF. It depends the image we see. It's actually, but anterior approach, I think so.
For me,
Yeah, please.
yeah, I think for localized OPOL, I prefer the ACDF. But you have to use microscope. You have a high-speed drill, and I think you should take a long time to remove the ossification, because there are a lot of risk from this strategy. For example, Durantier or deficit, neurological deficit. So I think very carefully if you want to remove the ossification. Yes, that's my opinion.
Okay, thank you, Dr. Hao.
I totally agree with Dr. Hao, because, in very long time ago, I met cases, but I did a wrong diagnosis. Before surgery, I diagnosed, like a simple disc herniation of C5, C6, but actually it was a circumscribed, Opll, because before surgery, we, ignore to do the CT scan to, clarify, to visualize a better image of the lesion, that adjacent to the, the posterior, wall of the spine. So when we did surgery, of course, we have a drill, we have a speed drill, and we have microsurgical, instruments, but it is very difficult to remove the disc, but actually it is Opll. And so, I met, a, complication in that neural tear. That is a big problem in my life, I remember until now. So that's why, I always did the CT scan or X-ray very carefully to diagnose, differentiate the OPLL before surgery. And Dr. Ho, I think the ACDF, current evidence suggests that the anterior approach is preferred for the key line negative OPLL, and posterior approach is preferred for the K line positive OPLL with the canal occupying ratio less than 50 to 60%. Dr. Ho. Okay. Thank you.
Okay, I also agree with Dr. Hao and Dr. Bao. If we can remove the mass OPL, it's the best. That is the best because it's compressed from directory, and we decompress the directories. But before we decide to do anterior approach, we must think the two problems. First is complication CSF leakage, and the second when we remove the mass configuration. But if we don't remove the mass totally, maybe it's not enough decompressions. It's just two things you should think before you do surgeries.
Thank you, Dr. Hao.
Prof, sorry?
Yeah, Dr. Barbara, please.
Yes, yeah, for regarding your questions, if there is a preference to do the corpectomy plus and removal of a posterior ligament, I think it is if it's only 2 levels, I always prefer to go for the posterior. But now, if I must do the anterior approach, yes, I can still do corpectomy to 2 levels, but I won't touch the posterior ligament because it's too risky during the procedure to remove it. We can damage this. We can damage our spinal cord. That's one. And second, I can still doing corpectomy, anterior corpectomy, or I can combine like anterior and posterior the same operation, like 360 surgery. But I will not touch the anterior ligaments, the posterior ligaments, sorry.
Yeah, I agree with Dr. Barbara. I think you can do this. It's okay, and to say more about the anterior approach. It's not only the ACDF techniques or compatibility techniques. There are many modified techniques. I have. So, for example, oblique techniques, for floating techniques, for example. Yes, but of course, if you can do, you do. But if not, you can do by yourselves. I think it's okay. It's not. It's not something. It's not a big problem when we choose that.
Yes, it's really difficult to remove the calcification, the ossification directly from the anterior approach. Even when you have own material like high drain speed, it's not easy to remove because sometimes we make damage the spinal cord. and sometimes sometimes we cannot remove because the attachment between the dura with the calcification is not easy. Usually, you can find it is very good point when we decompress at the point of compression by anterior approach, but it's not easy. In fact, it's not easy. It's very dangerous. And if we do only the plastic, the laminectomy and plastic, it's very simple approach, simple procedure. It's not complicated. Yes, I agree with that. Thank you very much. And there are some other comment or question?
And your doctors, your young doctors, very good. You know, they collect a lot of you know, the medical articles, very updated, and systemized everything for us to study again. Because Dr. Man already studied and collected a lot of very good, valuable scientific data about the Opll and present to us. So we don't need to do it, but we just look at their presentation and we can learn of everything. Thank you very much.
Yeah, thank you very much.
Thank you, Doctor.
And Dr. V. Chung Sơn, do you have Dr. V. Chung Sơn? You'd like to talk something. Dr. Sơn, please.
Good evening, Doctor and everybody. Can you hear me?
Yeah, right. Please.
Okay. Thank you very much for your webinar. Totally with the short segment. Totally, I agree with Dr. Hậu and Dr. Mạnh. We use HCDF, but in my opinion, we should choose the bone scraper system. It's very new system. The burr system, it can easy to remove the Opll, and it's very safe for the protect the dura to avoid the dura tear. Yeah, this is my experience. Thank you so much. Yeah.
Excuse me, Dr. Sun. Can you explain more detail about the bone scraper system?
The bone scraper system is quite the Metronic company. I use it for maybe 3 or 4 kids. It's for the demo. Yeah, I find that it can use the bone, and it's very safe. It can we can pour the water during the time we burn the bone, and it's not it can control the speed, and to make sure to remove the bone is to remove the bone, to make sure it's it can control the speed, and it's very slowly to remove the bone, and it's can protect the dura. Yeah, that's the system I know about it. Yeah, because we can protect, we can practice it on the eggs. You know, the eggs. We can burn the eggs and without destroy the inside the egg. Yeah. So I think it's very convenient for us. Yeah.
Have you ever used this for APLLs? Until
yeah, we use maybe 2 kids, and very safe for the avoid the dura tear. Yeah. And maybe some surgeon, maybe Dr. Võ Xuân Sơn in Ho Chi Minh City, he can buy it for his clinic hospital, for private hospital, his private hospital. Yeah.
It's
Thank you so much.
it's an ultrasound system machine.
Sorry,
It's in ultrasound.
no, it's not ultrasound. Yeah,
Yeah.
it's a quite very modern system for the birth system. Yeah.
Okay, thank you very much. Do you have some more question or comment, Dr. Bao?
Okay, just one question, but not for medical.
Yeah.
Just English.
Yeah.
I saw a lot of my colleagues to use a tear, not tear. Tear is a teardrop.
Yeah.
Tear is a laceration. Laceration là rách is not tear. Tear is a nước mắt. Okay, just English. Okay, I don't mean to hurt anybody, but I just want to say that. Tear.
Okay, thank you very
Tear.
much.
Euro tear, not Euro
Yeah.
tear. Okay, just for fun anyway.
The
Thank
common
you.
Okay, thank you very much, Bao.
Okay, so thank you very much for a very nice evening, and now we can go sleep. Yesterday I was on duty. I'm so tired.
Okay,
Thank you very
much.
Thank you very much, Doctor.
Yeah, it's time to leave. Dr. Thien, do you have some word? Okay, thank you very much. On behalf of the committee organizer, I would like to say many thanks to Dr. Thien, Dr. Bao, Dr. Ho, and Dr. Hiệp, and also Dr. Mạnh and Dr. Tâm. Thank you, everybody, and good night.
Good night, everyone.
Good night.
Good night.
Goodbye.